very familiar with it, I'm sure, but it was proven to be to save lives. So everybody started a program, and there's a lot of different ways that the lung cancer screening program is happening. The criteria. We all know probably the 30 pack years or 30 plus pack years of smoking history, 15 years since you've quit smoking. But what's the age? U.S. Preventive Task Force says 55 to 80. Depends on who you look at, right. So you get referrals from doctors for lung cancer screening, and I'm like, well, wait a minute, this patient's 79. Well, the U.S. Preventive Task Force says we should do lung cancer screening. Okay, let's do it. The ACS says 55 to 74. CDC says 55 to 79. Medicare, I guess, rules. They say 55 to 77. So anyway, what are some of the barriers? The biggest one is knowledge. Most people haven't heard of lung cancer screening, even though we've been doing it. Medicare's been covering it since 2015. A lot of people haven't heard of it. Primary care providers aren't always on board and forthcoming with screening. They're going to talk about your mammograms. They're going to talk about your colonoscopies. They're going to maybe talk about a PSA. They're going to talk about making sure your pap smears are done. They're not going to mention your lung cancer screening, even though they are going to document in the same breath that you're a smoker or that your pack year history is 150 or whatever it is. And there's reasons for that. They're bombarded with a lot of information. They're scared if they do a lung cancer screening, it's going to show a lot of incidental findings, and they're going to have to follow up on those. They're going to have to follow up on the lung cancer screening somehow, and they've got enough to keep up with already. So I think it's a lot of fear of opening up a can of worms for primary care providers. And so we have to work on helping them understand the importance and then helping them manage some of their fears. The other thing is money. A lot of our patients, even though insurance is going to cover this, they might get a deductible or copay. Patients get billed $200-300 easy for this, even though they have insurance. At least that's where I'm at. That's, they get billed up to $500, if they haven't met deductibles and things like that. We are very fortunate. We have a fund that was set up specifically for lung cancer screening from a private donation from a family that had lost somebody to lung cancer, so that they could hopefully help someone find a lung cancer early and save their life. And so because of that fund, we are able to tell people that, yes, have your scan. If you get a copay or deductible bill, we can help you with that. And that's huge because people are afraid of their medical bills. Even though they understand the importance of it, we all have financial burdens and we try to avoid them. The other fear is people are scared that they're going to find something wrong. They're scared of being diagnosed with lung cancer. You got to do some education because they have the myth that if they have lung cancer, it's a death sentence and they don't need treatment or there's not going to be any treatment that's going to help them. So educating them to lung cancer early stage diagnosis and prognosis is important. That's a big deal. And the other one is there's arguments that lung cancer screening allows patients to continue to smoke and it encourages them to continue to smoke because you're told them they don't have lung cancer, so keep on smoking. In my experience, that's not the case. Actually, it's the opposite, which I was surprised. But when I'm contacting patients, they're due for their annual follow-up scan. A lot of them, and I get an update for their smoking history. How much did you smoke this past year? Oh, I quit 3 months ago. I quit 6 months ago. And it just shocks me every time because people don't quit smoking. It's reality. People don't quit smoking. They smoke forever. And unless they have a major health problem, they don't quit. Well, I believe that screening allows them to realize that it is important to quit because even though they may not have lung cancer, they have emphysema, and we tell them about that. They have coronary artery atherosclerosis. They have other things. They have small nodules that they're scared are going to grow at their next follow-up scan. So they do quit smoking. My involvement with lung cancer screening came in 2015. My nurse manager, the one that taught me into being a nurse navigator to start with, she came to me and wanted me as part of our program to develop a lung cancer screening program to run simultaneously with the navigation. So that was really scope creep, but it's worked out. And I did that and tried to juggle both lung cancer navigation and screening. And it was hard, and sometimes it was overwhelming, but ultimately we made a case for and got a second nurse navigator one to focus on the direct patient thoracic navigation. And that allowed me last January 2018 to focus almost solely on lung cancer screening navigation. And since then, in 2018, we increased our lung screening numbers by 46%. As of now, we've got over 1,000 patients that are in our program. Most of those have had more than one scan. Some of them have had scans since 2015. Since 2015, we've diagnosed 31 patients with lung cancer. There's a handful of others that are in a very close observation or being worked up. But just since January, we've diagnosed 13 patients with lung cancer. That's a lot. That goes much beyond the statistical likelihood. So anyway, what we're doing is good. I'm happy with our program. I love it. I'm looking for ways to expand it into a regular nodule program. But anyway, lung screening, it gets 2 thumbs up. It also has incidental findings, which we mentioned could be a barrier for PCPs. But they're not really a barrier. Incidental findings a lot of times are things that should be found. We've found lymphoma. We found several kidney cancers. Let's see what else. We found a lot of arteries that need stents. We even found a pancreatic cancer and a breast cancer. So anyway, let's move on. So it's an exciting time to be a lung cancer navigator. I don't think anybody would argue that. We've had the last 2 years, I think there's been twice the number of drugs approved that there had been for the 10 years prior to that. So it's a very exciting time to be a nurse navigator for lung cancer. I'm going to go over some of the basic, or not really basic, but I'm going to go over the current approved treatment trends and cover those. I'm not trying to tell you everything about these drugs because they're going to change. The use is going to change. I'm going to try to impress upon you the importance of staying up to date and never getting stagnant with your education, because there's always going to be new things out there. And so my recommendation and what I've done is to go to the source. When there's a new treatment out there, go watch it. Talk to your radiation people, talk to your physicist. I hooked up with our physicist and went through, met with her and went through an SBRT treatment to see exactly what that patient was going to experience. I went and met with a pulmonologist and watched bronchoscopy when I first started navigating. Then I watched the navigation bronchoscopy when we got that. Our thoracic surgeons love to teach usually. So connecting with them, going into the OR with them, watching the surgeries, all that lets you speak from firsthand experience when you're telling your patients what to expect, because your patients want to know what to expect. And if you're reading them stuff from a book or showing them a pamphlet, that's good, but being able to say, these are some of the things that you can watch out for. This is what you should experience or could experience. Those are very vital and very important. So non-small cell lung cancer. Everybody knows that if we can catch it early, surgery is the way to go. It's been the gold standard for quite some time for stage 1, 2, sometimes 3 disease. That all depends on your PFTs, your comorbidities. You're used to weighing those out, I'm sure. There's now more use of neoadjuvant treatment before surgery. Well, that's what neoadjuvant is. So there's more use to make surgeries possible that in the past may not have been attempted. There's also now some use of adjuvant treatment for surgery patients for stage 2 and 3 disease, even if there are no positive nodes. Then there are VATS procedures, less morbidity, hopefully. Better outcome, patient more willing to proceed with that adjuvant treatment. And there's robotic-assisted surgery that's not widespread, but there is some of that used as well. Radiation. Everybody knows we do a lot of concurrent treatment. We do palliative treatment, bone mets, brain mets. We do SBRT, other stereotactic methods to treat lung cancers. It's a great second option if surgery is not a good option for a specific patient. It's got a very good rate of cure for early disease. Chemotherapy. We all know these drugs are some of the common ones we use, and we get good responses. Targeted therapy. I love our targeted therapy. Finding those driver mutations is awesome. It's like home run, because you have another weapon that you can use. We're coming up with new ways to use these treatments. The way I explain targeted therapy a lot of times to the patients It's kind of like an outlet plug, you know, that you put in an outlet to keep a kid from sticking a fork in there or their finger or something else. I've got 4 kids, so I've had a lot of experience with outlet plugs. My youngest is 2, and he's always just pulls them off and throws them in the trash. So anyway, but that outlet plug, that outlet plug is your drug. And if you go to the outlet, which is the cancer, and it matches up and it goes in there, it blocks that cancer. And if that's a driver mutation, it's stopping that cancer from vital processes that are going to keep it continuing to grow. Now, sometimes it figures out a way around that. It maybe gets an electrician to put in another outlet that's a different shape. It has a different mutation, but we're working on more drugs so that we can hit that shape too, and we can stop that as well. All right, immunotherapy, that's what everybody wants to talk about. And it's awesome, it's exciting. You know, you're basically pulling the brakes off of your immune system to attack the cancer cells. We're using it in first line instances in some cases. A very common way to think about this for patients is kind of like a police and a fake ID. So if you have your cancer cells, they're the bad guys out there. They've got fake IDs, while all the regular cells that are normal cells, they have their regular driver's license. And the police are constantly going around checking everybody, make sure they are who they are supposed to be and are who they say they are. Well, when they get to those fake ID people, they would keep going, except when we bring in our immunotherapy drugs, they're like, the little security guys that run around and they swipe the fake ID because they can tell which one's fake and which one's real. Swipe the fake IDs, our immune system, the police there, they say, oh, there's cancer cells, so they are targeting those cells and killing them. Small cell lung cancer, we all know it's very aggressive. I've seen it double in size in a couple weeks. Do we do surgery for it? Most people would say no, but now we do sometimes. And at least in years past, I was always told no. By the time you find it, there's an assumption that it's spread even if there is no evidence. But now, if you're node negative and it looks manageable, it's small, you do surgery. And afterwards, you do adjuvant treatment. And I think that's awesome to be able to offer that. Radiation. So we do concurrent radiation. You're used to that probably. We do prophylactic cranial irradiation. We do palliative bone met radiation. Chemotherapy. Chemotherapy is awesome for small cell. If there's ever a silver lining to tell a patient that they have advanced small cell lung cancer, which there's not many silver linings, but tell them that this chemotherapy that they are considering will melt a lot of that away, and to not be sugarcoating it is really good, and it gives patients hope. Even if you are telling them in the same breath that it's very likely to come back, even if we completely get rid of it. But to be able to have that big response where that's another thing. You've seen it just like I have. I've had a patient on O2, 3 or 4 liters, laying in a bed, couldn't get up because of shortness of breath and his disease burden. Within 2 to 3 weeks, he's walking in the clinic without oxygen, saying he's feeling better than he has in months. So chemotherapy is awesome for small cell. But now, immunotherapy. You know, for the first time in almost 20 years, we have a new treatment for small cell lung cancer. I think that's just awesome because one is going to lead to 2, and that leads to more, and it's going to lead to better outcomes, more cures. So we have a lot of emerging treatments. There is so much research going on now. It is an awesome time to be a navigator, and it just proves how important it is to have navigation for lung cancer patients. Liquid biopsies are in the works, and they are good. They are you probably heard a lot of the research coming out. They are very good. I'm very interested to see how they're actually utilized in clinical practice in the next year and 2 years. We've got intraoperative brachytherapy. The early trials of this haven't been so good, so I don't know if that's going to continue to be studied, but that's a very novel approach. Surgery versus SBRT. There's been a few studies, but there's several more out there that, the thought is that it's going to be really close to as effective as surgery for early stage disease, which is awesome if you have dealt with a lot of the complications from surgery compared with virtually no complications from SBRT done on appropriate patients. So that's a really awesome concept, and hopefully the studies that are out there will prove that. More targeted drugs. I read somewhere, and I'm sorry I don't know where, but there's I forget, I think around 1,000 studies going on now, specifically for lung cancer drugs. I mean, there's probably a lot more than that, I don't know, but we are gonna have more targeted, more immunotherapy drugs, and that is gonna make care more complicated, but also more effective. We're gonna find different ways to use immunotherapy. We're still in the infancy of immunotherapy. So there's gonna be different combinations with chemotherapy, with targeted drugs. What can we do to increase the effects of it and decrease some of the side effects? Adoptive T cell therapy, that is exciting. You know, the idea of taking your T cells out, making them supercharged, turning these regular little people T cells into the Hulk, and then giving them sniper rifles. I mean, that's just, you know, and then sending them back in there to find the cancer that you've already given them a GPS coordinate to find it. I mean, it's awesome. So anyway, therapeutic vaccines and chemo prevention. There are so many new things that are up and coming that it's just an exciting time. But we do have more barriers. We have treatment barriers. Back to Bonnie. Y'all remember Bonnie. She had transportation issues. She had diabetes. She had MI, seizure disorder. Bonnie, I told you about her teeth. She had infected teeth. I don't know if anybody's ever tried to find somebody to work on some bad teeth while somebody's getting chemotherapy and on Medicaid only. It's not easy. So be aware of a lot of the barriers we've already mentioned, and also there's new ones. There's fear. Patients that have guilt, they may not be as compliant with treatment. They may not be agreeable with some treatment because they have guilt or feel shame because they did it to themselves and they don't want to take immunotherapy because they know how much it may cost. These are potential barriers. Be aware of patients that have diabetes. They're getting steroids. You know what happens there. People getting a lot of IV fluids that have heart problems. There's PEs. There's a lot of things out there that as a navigator you can be aware of and attentive to and potentially head off problems. So speed bumps, these are treatment side effects. We don't want them to derail us. The most important thing to take away from treatment side effects is that they can't cause delays in treatment because that impacts your outcomes. So you want to prepare for the expected side effects. Your chemo classes do a good job of that, but I don't know about your specific places of practice, but our facility does very drug-specific generic education, meaning if somebody's getting Taxol, that's what they teach about is Taxol. They don't look at your dosage. They don't look at, is this concurrent and you have a lower chemo dose? Is this, how are you using this treatment? Is this a curative intent? Is this palliative intent? So being aware of what symptoms your patient's likely to have and preparing them for that is important. Also be aware if they're getting targeted drugs and immunotherapy, they're going to have different symptoms. They're going to have the rashes, diarrhea, constipation. If they're getting immunotherapy, you have to look out for problems where the immune system gets a little too crazy and attacks other organs. Is that your CT scan result that looks like disease progression? Is that really just immune-related pneumonitis? There's a lot of factors to be aware of potential side effects to prevent problems. So when your patient finishes treatment, everybody's celebrating, right? At our cancer center, we have a gong. It's a giant bell thing that you ring, and excuse me. And your patients ring it. Some of them just ding it a little bit. Some of them knock it, and it echoes. But you're cheering for the patient. But it's not all rainbows sometimes, because in the back of your mind, you're thinking, it might come back, or it probably will come back, because you know the statistics. But for your patient, it's also hard, because all of a sudden they're at home, life goes on for the rest of their family, because they're done, they're cured, or they're in, there's no disease, there's no treatment right now. So what do? They're not at the cancer center where somebody's watching to make sure their cancer's not coming back. They're not getting treatment to make sure they're doing something for it. So there's a lot of anxiety. There's a lot of uncertainty. And they're still dealing with side effects from their treatment. They're dealing with neuropathy. They're dealing with radiation pneumonitis, potential problems from radiation to the brain. They're dealing with side effects from their treatments. So it's a time where you want to support them. Survivorship programs help, but being aware of the risk for depression and anxiety is important too. This is my parents. I'm going to try to be brief because I think I'm running out of time. Anybody? I'm okay for about 10 minutes, Mo?
No.
5?
1 minute.
1 minute?
Yeah.
Oh, okay.
We're going to have time for a couple questions.
Okay, so I'll make it as quick as I can. My parents, my dad there is 80. He's an Energizer Bunny. He had prostate cancer a number of years ago, robotic surgery. He plays competitive softball, competitive basketball. When he had a hurt in the shoulder, his first thought was, oh gosh, it's went to my bones. And it wasn't that, it was a sports injury. So anyway, fear of recurrence is always with patients. I don't have time for a video that I want to share, but if you will Google the name Doris Cardwell, DorisCardwell, and look for a TEDx program from Rapid, was that South Dakota? That's where she lives now, South Dakota. Anyway, close personal friend, watch that video. I promise you won't be wasting your time. I've got 24 seconds. So Bonnie, very quickly, Bonnie was in room 124. We had exhausted all of the options. Her breast cancer had come back. Her breast cancer was progressing. There were no other treatment options. She's not responsive for listening to the physician. And I knew it was my obligation to go in there and try to talk to Bonnie and try to help her with this phase of her journey. So I went up there. It took multiple times to catch Bonnie when she didn't have a family member with her, which is crazy because Bonnie didn't have any family. All of a sudden she does. So anyway, I found her without her family. I'm there at the bedside on one knee holding her hand, and I tell Bonnie, you're not going to beat this disease. I love you, and I hate to tell you that, but you're not going to beat it, but you don't have to let it beat you either. Whatever time you have left, you do the things that are important to you. Talk to the people that are important to you. Get the help that you need, even if that's hospice and you are scared to death of the idea of a hospice nurse. You do this phase of your life on your terms, and you are not letting this disease beat you. Bonnie died 2 days after that. Now, I wish I had been able to see Bonnie sooner and not dodged her family, or dodged her family a little bit better. Anyway, just know that lung cancer navigation is the most challenging job that I've ever done, but it's also the most rewarding, and it's the job I never, ever thought I would do. So please keep advocating for your patients, empowering them to make their decisions, push to do what you do, even better than you're already doing it, and know that what you're doing really, really matters. And now we have to go to our survey, if you will. I'll read through these quickly. Please indicate how often you now plan to use the following strategies when you're working with your patient.